So the first case is from a patient of elder female. An elder female, she received bilateral ureteroscope and a bilateral renal pelvis sampling. According to the report from the scope examination, she was found to have a papillary tumor in the right renal pelvis, and in the left renal pelvis is relatively unremarkable. The doctor didn't see anything over there, so he just do a washing cytology. So we receive washing cytology from both sides of the kidney. The patient also had a past history of high-grade urothelial carcinoma and the carcinoma in situ of the urinary bladder. So remember that by scope there is a tumor on the right side and there's no tumor on the left side. So we take a look at the left side cytology first. So because it is a washing cytology, we see a lot of cells, some in fragment, but majority of them were actually single cells. Just on this power, you can appreciate that the nucleus is pretty big. So we go to higher power. I think the specimen is relatively straightforward for high-grade urothelial carcinoma. So you can see classical changes of, first of all, you can just take a look, find the reference cell. So here we do have active reactive lymphocyte over here. So this is the normal cells. And then you see in adjacent, all these individual cells show enlarged nucleus and very, very high NC ratio, as well as coarse chromatin pattern. So these are typical for high-grade urothelial carcinoma, and these typical cells are throughout the entire specimen, including single cell as well as in cell cluster. So this is like unequivocally, this is a high-grade urothelial carcinoma specimen. However, if we remember, she doesn't have the tumor on the left side. And there is another specimen from the right side, which the clinician find that is a papillary tumor. So again, this is a washing cytology, so we see hypercellularity and we see fragment of cell as well as single cell. So if we go to higher power, you can appreciate that these cells has a relatively low grade TPR compared to the previous specimen. So the size of the nucleus is not as big as the previous specimen. The NC ratio is not as high as the previous specimen. The chromatin pattern is very delicate, it's very uniform. However, something is unusual, that is these relatively high NC ratio and low-grade cells are abundant and have these very monotonous appearance. And it doesn't look like the normal intermediate cell that we would see in a urine specimen, because the NC ratio is relatively higher. The nuclear is relatively uniform, monotonous, and slightly bigger. And we do see some really high NC ratio cells, but again, the chromatin pattern are relatively delicate, and size of the nuclear is smaller than the previous specimen. So this is actually a very classic presentation of a low-grade urothelial neoplasm. So whenever we can diagnose low-grade urothelial neoplasm, there were a couple scenarios The one that we can definitely call is when we see unequivocally large fragment of papilla lined by a very monotonous cell. And in this specimen, we do not see any papilla, but we see like an ocean of a very monotonous cell population with relatively increased NC ratio in the size of the nucleus, and these all looks very monotonous. So whenever we receive these type of specimen, our reporting based on the Perry system that we should still call this negative for high-grade urothelial carcinoma, but we will make a note to mention that low-grade urothelial carcinoma cannot be excluded. And in our hospital, we do not use the Perry system terminology. We use the criteria, but we don't use the terminology. So in our hospital, we will call these atypical because we see plenty of atypical cells, and we mentioned that rule out or low-grade urothelial carcinoma or low-grade urothelial neoplasm. That's the term that we prefer to use because low-grade urothelial carcinoma and the Pond lump may have very similar cytomorphologic feature. So we call these typical, and low-grade urothelial neoplasm is considered. So what's happening? So the first question that we want to ask is that could it be a switch of the specimen, because they do see a papillary lesion on the right side and they don't see anything on the left side. So I was wondering if we switch the specimen, and then I find out that on the right side they do have a biopsy from the renal pelvis. Additionally, I checked in the prior history that the patient already had the previous, probably 3 months ago, she had a diagnosis of low-grade urothelial carcinoma on the right side. So indeed, these right side specimen reflect the previous pathology as well as the current biopsy. We have seen the similar finding, low-grade papillary tumor. 运动吗？是什么？哦，好，那你寄回来，谢谢。So we have a low-grade urothelial carcinoma on the right side, and we have possibly carcinoma in situ or a very occult lesion hiding within the calyx of high-grade urothelial carcinoma that was not identified from the scope examination, but the washing cytology is unequivocal. This is definite for high-grade urothelial carcinoma. So this is the application of the washing cytology, because most of the time you will have a correlated biopsy, but sometimes, especially in these very tiny tube of urinary tract, there might be some lesion. It's very difficult for the scope to identify, because if there is an angle and the lesion is in the lower portion of the renal pelvis or deep in the calyx, sometimes you won't be able to identify from the scope. But if you do a washing cytology, it is diagnostic. The specimen is diagnostic for high-grade urothelial carcinoma. So we need to pay attention for the laterality, because sometimes, rarely, it can have a switch of the specimen, and the consequence could be severe because the subsequent management is likely a nephrectomy. So we need to pay attention if there is a possibility that the specimen has been switched. But we also need to know that the papillary tumor can be low grade, not necessarily high grade. And we have very good morphologic pattern for both sides, and you have good demonstration of on one side is high grade, on the other side is a low grade, typical low grade urothelial carcinoma morphology. So 这个再还给燕伦，我先去拿一下冰冻，我们先暂停一下。不好意思。
然后就我就想，今天怎么闹钟还没有响好久？时间到了，然后我就说好了，我们来个突然站起来。
学术方面小心吧，就是4月20号那个如果台阶节飞，
我一直坐在位置上没有动。
因为台湾是还有1个钟。
哦，
不好意思。
好哦。
因为我觉得，
所以已经知道分配什么。
我确定也可能待会可以往旁边。
哦，好好好。
没那么快。
哦，好。
We got the early frozen真富。很小颗啦哈。It's a sentinel lymph node. Very small. So this is benign.运动。林焕秋、慧敏，右侧 sentinel lymph node benign。好，谢谢。好，我们再继续。所以影片没有暂停哦，我还以为有先暂停一下。OK， 好，没关系。The next specimen is a uncommon specimen. It's a specimen from eye. So we have a younger attending doctor from the Department of Ophthalmology who learned ocular oncology from the States and coming back and keep on asking us to make specific diagnosis on very limited specimen. He say that he already sample a lot of tissue, but sometimes we just don't see any cells. So that's why when now if we receive the specimen from eye, please let me know, and I would like to take a look of the sample to see what's happening. For this specimen, this is a 54-year-old female, and clinically she was suspected to have a melanoma inside the eye. Because the retina also have a lot of melanocytes, so it is also a site can develop malignant tumor arising from these melanocytes. So in this specimen, I would say the specimen would be similar to the CSF specimen because usually we will receive very clear fluid sample. Sometimes you can see some like a tissue fragment, particularly a very black or dark staining specimen floating around. So this would be the specimen that we would try to keep it into a cell block preparation. But because the sample is mostly from the retina, sometimes from the vitreous, but mostly from the retina. So you can actually get some normal retina cells component, which may look like these with pigmentation. The cells are small. For these specimens, we do see a lot of single cells with naked nucleolus in the background, and the cells are mostly in spindle shape, and it is slightly enlarged. And I would say that the cell does has some atypia. So if you comparing to, we don't have a lot of reference, but if you, yeah, we do have reference. If this is like a reactive lymphocytes, this is much bigger, right? And if you take a look of the cells, you can appreciate that they seems to be have some pigmentation in the cytoplasm, and the shape of the nucleus is strange. It's spindly. It's not perfectly round. So this looks like quite suspicious. So we do have a few some atypical cells inside the cytoplasm. We do see the pigment, so it is likely melanocytic origin. However, we still need to distinguish if these can be a melanophage, which is a histiocyte engulfing the melanin pigment. But again, you do see the cell has a very strange shape, like a kidney, and with very irregular nuclear contour, as well as a small but distinct nucleus here as well. So we are more toward the melanoma side. I would say these focus would be diagnostic. So as a cytopathologist, we used to make diagnosis out of very limited specimens. So we really need to identify at least one focus that would be they will feel very comfortable to make a definite diagnosis. So I think this cluster I would feel comfortable because I do see marked nuclear atypia. Each of the cells has a very distinct nucleolus, and the cells show very tight, crowded, overlapping arrangement. In the cytoplasm, it does has abundant, finely granular melanin pigment, suggests that it is a melanocytic differentiated cell. So even though we don't have a very good stain, I think the stain is too light, but still I would feel comfortable to make malignant diagnosis based on these cluster of cells. So because we do have some residual specimens, and it seems that the specimen looks either like a lot of blood cut in the bottom, or could be a blood cut admixed with some tumor cells. So we would do a cell block for that residual specimen, and if we find more cell, we can probably use immunohistochemistry to confirm the differentiation. However, to confirm the differentiation, we still don't know if it is tumor, if it is malignant, or it is just a benign melanocytic cells. So to make that distinction, we will require morphology. So by morphology here, it is malignant, okay? So I think we are confirmed that there is a malignant tumor in the eye compatible with clinical impression, which is a melanoma. So we may, I think we can do definite diagnosis out of these specific specimen. And there will be another patient suspect to have eye melanoma on Thursday. So when you receive the specimen, please call me, and I want to see what's inside the liquid specimen. So that is an uncommon specimen, uncommon diagnosis, but especially for the eye, I think everybody would understand that we are very cautious for this type of specimen, because first of all, it's a very important organ. Second of all, it's a very tiny organ, so we can only get very limited like a cell. So we need to try our best to preserve the material for the diagnosis as much as possible. Otherwise, I wouldn't say the clinician he keep complain, but as a clinician to this patient as well, we pathology, I think we also have the responsibility to help the patient as well. So despite the clinician who is not very polite and keep complaining, but yeah, I think we still need to help the patient because I think he's also very anxious about the patient's condition and we want to have the best for him. So let's try to do it together to make a better diagnosis. So let's try to check for the eye specimen. We now try to be more careful on performing any preparation on that type of specimen. Okay, so the next one is pretty easy. This is pleura effusion from a patient with lung cancer. So this is metastatic adenocarcinoma. So we have nice three-dimensional cluster of glandular cells. And the cell morphology, you can easily appreciate that it has overlapping nucleus. It has vesicular chromatin, prominent nucleolus. It has marked polymorphism. So this is what we see every day. This is a classic example of lung adenocarcinoma in the body fluid specimen. But if we receive a specimen with that high tumor cellularity, it is very easy that we can get floater from that. So that's a big problem. So this is a specimen from a different patient. The cytology number is around like a 7 or 8 behind this number. This is a specimen from a pleura effusion as well, but the patient was suspect to have empyema, which is the abscess in the pleura cavity. So in the background, we do see like inflammatory exudates with a lot of neutrophil and very like a sticky debris in the background. So this is compatible with abscess formation. So we will say this is a negative specimen with inflammatory exudates compatible with empyema. Okay? But at the periphery, if you take a look, it's just at the edges of the slide. There were 2 dots highlighted to a typical cell cluster. Have exactly the same morphology as what we see in the pleura effusion specimen, right? So based on first the distribution, if the patient does has adenocarcinoma in the liquid fluid, supposedly the distribution of the lesional cell, of the tumor cell, would be very homogeneous. It should not be only present at the edges of the slide. So if you only see at the edge of the slides, out of the clinical impression, it's a abscess. It is not a tumor, but you see something atypical. You need to think about the possibility of the floater. So this is why we will want to see every day all the positive specimens together, because if you only see the individual cell cluster, you can make malignant diagnosis out of this patient. So again, our cytotech is very alert about the situation, which is very good. And our cytochem can also compare the morphology, say, oh, this is likely floater from the other specimen, and I totally agree. So we will make a note in our documentation, and as well as we need to put the word floater on these slides. So whenever anyone retrieve the slide, they will know these are floater. These are not from the patient. Okay, so this is very important. And to compare the morphology, as well as to identify the distribution, which is not typical for a primary specimen that have a cancer, it is very, very important.
那个 photo 最可能在哪里？在酒精溶液还是在？
对，在酒精固定的时候。
在酒精的那一盆。
对，所以我们通常遇到那种 So whenever we receive a very cellular specimen with a very, very high tumor burden, like this specimen, this is the, you see from the low power, basically the tumor cell is everywhere, and when we do a cytospin and we do a smear, it is throughout the entire of the slice. So if you have more experience when you do the smear, you will know that this is highly likely that the specimen has a very high tumor burden. So when we think about that, it is recommended that to just put the specimen in a separate, in an individual, like a fixation flask, or you can just use 火箭筒, just put it individually over there, not to mix with the other. That would be ideal. So let's take a look of the cell block preparation. Again, you see, this is all tumor cells, right? Yeah, so whenever you see something like this, it's ideally that you just fix it in a separate alcohol, like a flask. Additionally, now we know that it has a floater, so we need to like a filter our fixation like alcohol solution in the fixation flask, because it might still have some tumor cell at the bottom. So that is quite important that we need to know. Okay, and we're taking longer for today, but we have some important cases, some unusual cases that I want to show you. So this is a specimen from ascites. On the requisition sheet, it says that the patient had cirrhosis, liver cirrhosis. So in the patient with severe liver cirrhosis, it is very common that we can see a lot of reactive mesothelial cells. Sometimes these reactive mesothelial cells can mimicking malignant tumor. However, I would say the specimen is already exceeding the morphology of a reactive mesothelial cell. For a reactive mesothelial cell, if it is a mesothelial cells, it is uncommon. It is not uncommon. You can see so-called double contour of the nuclear membrane, and the arrangement can also show so-called intercellular window may look like this. The cell can be enlarged with open chromatin and with distinct nucleus in the center. So if you say, oh, this could be a reactive mesothelial cell, I cannot argue with that, because it does fulfill all the criteria that I just mentioned. However, as I told you before, it is highly unlikely that we will see a vacuole in the mesothelial cell produce a signaling cell morphology. Especially in this vacuole, you can appreciate there's a little bit of yellow or oranges, like a color, may suggest that it is a mucin material. So again, poorly differentiated adenocarcinoma can mimic reactive mesothelial cells. So you see these are Indian file, you see intercellular window, you see vague, like a double contour of the membrane. So these may look like a mesothelial cells. However, these we start to see eccentric nucleus. We start to see signaling cell morphology, and in this cluster, you start to appreciate that the chromatin pattern is irregular. The shape of the nucleus is very strange in this elongated shape. So these start to make you feel like, okay, these can be a fully differentiated adenocarcinoma. Again, you see tight three-dimensional cluster with cytoplasmic vacuolization. These looks like adenocarcinoma. And here, mucin, signaling cell, and in very tight cluster. So these looks like adenocarcinoma. So if you can identify unequivocal focus of true adenocarcinoma, and then you will realize in the background, the cell mimicking mesothelial cell, reactive mesothelial cell, actually looks the same as these adenocarcinoma. So almost all the cells in this specimen are adenocarcinoma, fully differentiated. And the patient in last week, he has a biopsy from the stomach, and with a diagnosis of signaling cell carcinoma of stomach. So this is metastatic from the gastric cancer with a very typical morphologic pattern. Okay, so I just want to tell you that poorly differentiated carcinoma can often mimic reactive mesothelial cells. So you really need to have a very detailed examination of the cytomorphology, and to say, okay, this nucleus is too big, it is a little bit eccentric, the chromatin pattern is uneven, and the nuclear contour is irregular, and these are all taken together make you have a correct diagnosis, okay? So the next specimen is also very uncommon. This is a EUS guided aspiration of a pancreatic cancer, of a pancreatic mass. So first of all, in the background, we see a lot of necrosis. So we see a lot of cells in shadow without like a good standing of the nucleus. So we see prominent necrosis in these specimen. And we do see some atypical cells with enlarged nucleus and prominent nucleolus. So we start to think, okay, this specimen is suspicious to have a malignant cancer with marked necrosis. And I would say the preservation of this specimen is not very good. But in the background, we start to see a lot of like these highly atypical cells with a very strange shape of the nucleus. Sometimes it's big, sometimes it's angulated, elongated, sometimes you see multinucleation, and you do not see a very good glandular, like a tight glandular arrangement. So, so we are thinking, for example, this looks like a kidney shape of cells, individual cell, there's no tight cluster. So we start to think, okay, this is a malignant tumor. It is likely a malignant tumor, but the morphology is unusual for the adenocarcinoma of the pancreas that we usually see. It's mostly more well or to moderate differentiated, and sometimes you can see mucin in the cytoplasm. But these, you see these very spindle cells right next to epithelial cell is very strange. And some cells even had a so-called rhomboid type of feature. So again, these like a necrotic cluster, you see individual more preserved cells with high-grade nuclear feature. So the patient already had a liver biopsy, say that there is an undifferentiated carcinoma with INI1 deficient, and it was suspected to metastasize from this pancreas cancer. So most of the time, 95% of the pancreatic cancer will be adenocarcinoma, arising from the ductal differentiation tumor. There is a very rare subset of high-grade tumor that we call undifferentiated carcinoma. It can be negative for cytokeratin stain. and with a very anaplastic undifferentiated feature. So I would say that this is likely this is compatible with these diagnoses. So we do see carcinoma, and it does not show usual arrangement of adenocarcinoma, and it is more high grade than the usual adenocarcinoma, and so this is compatible with undifferentiated carcinoma of the primary pancreas. So this is the direct smear that you can appreciate these very high-grade morphologic pattern, very irregular, very gigantic nucleus of these atypical cell in the background of massive necrosis. So the patient does has a ascites specimen. I would say it is relatively difficult because the cellularity is very, very scant. So we have a cytospin preparation, 2 cytospin preparation from these patients' ascites specimen. So first of all, the cellularity is pretty scant. So in this specimen, I found only 2 clusters. I think this cluster is diagnostic for malignancy, right? So the nucleus is irregular. The nucleolus, one has a very big, like a triangle nucleolus. The other have 2 big nucleolus, and the shape are all very different. So these looks like the aspiration specimen that we just see, but there's only 2 cells. But this is malignant for sure. Comparing to the adjacent lymphocyte, these have the same size of the nucleolus, right? So this cell is malignant. And there is a second cells. Although it doesn't have cytoplasm, it is a naked cells. But you can appreciate that this is definitely malignant, right? Compared to the adjacent like benign cells. So we have only 3 cells, all have very bizarre, atypical feature, but we can still call these specimen positive. So the patient already had ascites metastasis. So for this specimen, there's only, I think, 3 millimeter specimen, and he submitted a second specimen of 18 millimeters fluid along with request for a cell block. So from the same patient, the specimen had a higher volume, but we failed to see well-preserved cell like what we see from a very limited specimen. So sometimes if it is a fluid specimen, if it has been placed still for a long time, sometimes the button, it will have a lot of blood clot and material, and sometimes there is no tumor over there, but only the very thin, very like a clear material may have a little bit of tumor cell. So it is not easy. So we know this is from the same patient, probably from the same specimen, just 2 different separate the specimen. And I only see one of these. I would say this is not very clear because the staining is not good because of the drying artifact, okay? But you can appreciate this could be a nucleus. If it is not a cell membrane, this could be a nucleus, and this could be a nucleolus. And this is a very big cells, but this is not very well preserved. And in the cell block preparation, I also didn't see anything. So for these specimen, I will probably just call these suspicious, and we have a very scant suspicious cell noted. And because it is not very well preserved, I'm a little bit reluctant to just directly call it positive. But the previous specimen, I feel more comfortable to just call it positive, okay? So we have a good correlation between the pancreas aspiration as well as the ascites specimen from the same day. So this is a CSF specimen. The patient has a history of breast cancer. Okay, so this is positive metastatic carcinoma, compatible with breast cancer history. So I will skip all the fine needle aspiration today, but I want to jump to the pap smear. This is the final case of today. So this is a 57-year-old female. So on low power field, we do see intermediate cells, a little bit superficial cell, but we do see a lot of very hyperchromatic, dark cells in the specimen. So the cell does has spindle shape. The chromatin pattern is hyperchromatic. Okay. So you will wonder that could it be a high CO? Because these type of cell, like a polygonal, high NC ratio, hyperchromasia, does give you like a feeling of this could be a high CO. And high CO can be in cluster as well as in dissociated single cells. However, first thing that we notice that is the distribution of the cell is highly unusual. If it is a precursor lesion, as what we say, this would be in a limited focus and along the direct smear because usually it's very limited. If you see the lesional cell is throughout the entire specimen, it is not a precursor lesion. It is most likely it is a very big lesion and likely invasive. So for this case, you were thinking about could this be a invasive squamous cell carcinoma? But the spindle is kind of unusual. And in the background, we do not see the typical tumor diastasis necrotic pattern that we used to see in SCC, and we do not see like a flankly keratinized cells. And then we start to see very bizarre tumor cells. So there is a hint scattered around the specimen. So if you take a look of the cell cluster, you start to appreciate that there were some pigments, just like the specimen from the eye. It looks like melanin. And so, as we know, melanoma is a great mimicker. It can mimic like a sarcoma because of predominant spindle cells. It can mimic in a carcinoma. And it can present with pseudo inclusion as well. So this is a vagina, a patient of vagina melanoma. Okay. So she already had a biopsy before, and she just want to check if the disease has recurrence or if there's any like a treatment response. But in this specimen, you can appreciate that it's throughout the tumor cell, so likely the treatment response is very poor. Okay, so the taking point is that to identify these like a scattered melanin pigment in the background and to make the correct diagnosis, because first of all, we have malignant looking cells. Second of all, we confirm the differentiation by presence of melanin pigment in the cytoplasm of these lesional cells. So these are melanocytic origin, not epithelial origin. So this is malignant melanoma. Okay. So that's all the case for today.
Thank you.